So thank you very much to Serban for the very kind invite to participate today. Unfortunately, I can't be there, but I'm grateful to participate. So we're going to talk about decision making and how we make decisions in clinical cardiology. I have no disclosures to make. So really, when we look back at decision making, Amos Tversky and Daniel Kahneman really were the leaders in this field who did much of the research, and they highlighted that often we're making decisions under conditions of uncertainty, which is the major challenge. We either use systems 1 or systems 2 thinking, which system 1 being intuitive, instinctual, fast thinking, which tends to be emotional and automatic, while systems 2 is more rational thinking, which tends to be slow, smart, and rational. Whether we make decisions is dictated often by whether there's a loss or gain to be made. This may influence our decision making. Also, we tend to use underlying heuristics or simple shortcuts in how we make decisions. So in this classic example of which of these lines is the longer line, many people believe that the bottom line is the longer line, while in fact they're equal in length. But an example of how heuristics can send us down the wrong pathway. So we started looking at this in 2018, and what became very clear is that there are significant underlying biases and traps to making decisions. So we commonly employ heuristics, which are shortcuts in how we make decisions. The decision-making environment may impact how we make decisions. For example, if the culture in an environment is very challenging, that may impact on how we make decisions. Asking the right question is really a key part of making the right decision. Seeing the unseen data that's present and being aware of underlying cognitive biases and whether we're framing the problem in the right way. So Abraham Wall during the Second World War highlighted that those airplanes coming back after the Battle of Britain had significant bullet holes in the wings, and what he realized was that the cockpit and fuselage needed to be reinforced in order to actually allow an improvement in survival of aircraft after dogfights. So that this was the survivorship bias that he pointed out. Likewise, the blind men and elephant Sufi parable, how we frame a problem depends really on how we see the problem. So if you're an interventional cardiologist, you may say everything is an interventional problem. If you're a surgeon, you may say it's an underlying congenital cardiac surgical problem. The electrophysiologist may feel it's an electrophysiology problem. So rather than looking at an individual part, we should be taking a more holistic view that it's the underlying problem with the patient. So there are several different pitfalls to decision making. We're all aware of the confirmation bias pitfall, where we see what we want to see. The groupthink bias, where we go with the group as opposed to being a dissenting voice. The status quo trap, where we've done something a certain way for a long period and we don't want to change. The sunk cost trap, where we've maybe gone down a very long pathway with the child. They've had maybe a DKS Norwood, bidirectional Glenn, maybe several stenting procedures and embolization of collateral procedures, and we realize that we keep going despite the fact that the right ventricle is in severe trouble and needing transplant assessment. There's also multiple heuristics, such as the availability heuristic, where we make decisions based on what's most available to us, the representativeness heuristic, where what's happened most recently impacts our decision, or the anchoring heuristic, where the first person who presents data directs the decision. So we started studying this in over 100 children who had decisions in our JCC back in 2018. This is a universal meeting that most departments meet often on a weekly basis, and we basically had two observers assess decision making and then compare it to the group, and we classified it based on simple or C1, C2, C3, C4 complexity, with C4 complexity being where there was no evidence base and there was a disagreement or lack of consensus on what should happen. And you'll see that there was actually very good inter-observer comparison with alpha Krontroff less than 0.5. So there was very similar agreement across the different classifications and also the C4 classification. So these were the different underlying lesions. C1 was a patient with progressive aortic regurgitation, which Ross procedure was recommended. C2 was a 6 kilogram baby with a moderate VSD with overload. and significant symptoms, in whom it was decided to do transcatheter VSD closure through carotid cut down. C3 was a complex isomerism, unbalanced AV canal with severe hypoplasia of the LV, with severe AV valve regurgitation, decision on an AV valve repair and a pulmonary artery band. And then C4 was a complex child with a non-compaction cardiomyopathy, hypertrophic cardiomyopathy variant with an aorto-LV tunnel, in whom there was differences of decision making between the group, but it was felt that eventually the decision was to transfer to a transplant center for aorto-LV tunnel surgical repair. We also found that sometimes the same decision is made in very identical, the same data results in very different decision making. So we had two patients with almost identical coarctations present over a 2-month period, one in whom we've decided on a transcatheter approach and the second in whom we decided on a surgical approach. So we did notice that when we mapped the discussion, we found that there tended to be an anchoring phenomenon in a number of cases. So this was in a child who underwent perimembranous VSD surgical closure, and we found that interventional closure, that when it was presented typically by the interventional group, there tended to be a progression to device closure. What we also found, though, is this is a complex child with Noonan syndrome deciding on pulmonary valve replacement, is that involving multiple stakeholders and having several different ways of framing the problem provided good decision making. And I think this reflected a very open culture in which everyone feels that they can contribute to the discussion on the patient. But some of the considerations that we should ask ourselves is which patients require discussion, how should patients be presented, who should share the MDT or JCC, should we avoid discussing patients before the JCC because of risk of anchoring, should we develop algorithms and also decision trees that may help with decision making. And we did this for our perimembranous VSD cohort in trying to make a logical algorithm that in those patients greater than 5 kilograms where it was suitable, that we would consider a transcarotid approach and closure of the device in the cath lab. Increasingly, machine learning is helping us as far as decision making, and this is being incorporated more and more so, looking at convolutional networks and deep learning networks in trying to improve prognosis of survival for patients, but also in decision making assists. We looked at this recently. It was published in a paper in Journal Cardiovascular Thoracic Surgery. A group from National Children's showed that ChatGPT was actually helpful in making a diagnosis, but that it didn't actually impact or help in decision making as far as the type of surgical intervention or the timing of surgery. So we need to be a little bit careful about how AI is incorporated into our decision making process. But I do think the future will be using AI as a decision assist in addition to human decision making. We also looked at how we manage uncertainty in decision making of common congenital cardiac defects, particularly in the MDT, trying to introduce a no interruption policy that all the data is presented, trying to have leaders refrain from making immediate decisions straight at before there's good discussion, formulating independent judgments prior to sharing recommendations, looking at potential external opinions, and trying to promote an environment that allows dissenting perspectives is important to mitigate against cognitive bias. So in conclusion, decision making is challenging in congenital heart disease. We know we often employ heuristics and biases, which may give rise to complex pitfalls. There are certain mitigating behaviors which can help against bias, including decision trees, standardized clinical assessment pathways, and AI may potentially mitigate against bias. But it's yet to be proved whether AI will prove a useful assist, and we need to be careful about its introduction, and it needs further validation. So thank you very much for the invite and the potential to talk today. Thank you very much also to Serban for reaching out and involving me in some of the future work that you guys are doing. Thank you.